Dear listeners, welcome to Faces of Digital Health, a podcast about digital health and how healthcare systems adopt technologies. I am your host, Tjasa Zajc, and this is the third episode of a short series about digital health in Africa. After hearing about Tanzania and Mobile Afya, which is bringing access to accurate medical information to people in Tanzania, and Nimedix, a company building a blockchain-based healthcare ecosystem in Nigeria, you will be listening about Rwanda today. In 2016, the UK-based company Babyl, which is radically transforming access to primary care in the NHS in the UK, opened a subsidiary in Rwanda. The Rwandan version of Babyl, called Babyl, has by today attracted over 2 out of 12 million people in Rwanda. As explains Patrick Singa Muhoza, the medical director at Babyl Health Rwanda, out of the 2 million people that have registered, 700,000 actually consulted Babyl's healthcare workers so far. Rwanda has 12 million people and a severely understaffed healthcare system. Less than 700 doctors work in the country. According to some locals, the problem of healthcare is not only the lack of doctors, but also poor knowledge of physicians, which can cause extreme differences in second opinions and makes people that can afford it search for healthcare in other countries. Babyl currently employs 100 local doctors and 120 nurses that work in a call center. Unlike in the UK, Canada or the US, Babyl is not primarily a smartphone app in Rwanda, but operates as a telehealth call center. You will hear more about the Rwandan healthcare system, the state of access to healthcare and the progress Babyl has made so far from Patrick Singa Muhoza. You can also find the recap of today's show and other episodes on our website www.facesofdigitalhealth.com. I also added the direct link to the transcript to the show notes. Now to Rwanda. Patrick, you are an MD, a medical doctor yourself. So tell me a little bit, when you get sick, where do you seek medical help in Rwanda, which only has 600 doctors for 12 million people?
First of all, as a medical doctor tend to be the most difficult patient possible. Our health-seeking behavior is very difficult. We tend to treat ourselves, which is really bad and really not advisable. So I'm not really keen at going to health facility to seek treatment. I avoid them as much as I can. But I would only seek care in a health facility when I really can't do otherwise, which is not something I would advise. It's not the right behavior.
This kind of makes me wonder, what is the state of prevention and, encouraging people to live well or to just visit the doctors when their health state isn't too grave yet? So what are the trends in Rwanda in that sense, just from the public health perspective?
I'm not alone in this wrong behavior. Generally, not only in Rwanda, but in Africa in general and elsewhere, I would imagine people or patients tend to only seek care when they can't do otherwise. I've seen it in my many years of practice here in Rwanda, where patients would get to me for care when sometimes I could not help them anymore because the condition has just got to a stage that is too advanced and requires a very high level of care. This makes my life hard as a medical doctor, but it's even harder for the patient in the sense that if the condition was treated earlier on, it could have been treated, let's say, at $1 as a price. But if the condition worsens, it turns up to be a $100 disease, which is very expensive for the patient. So indeed, prevention is less expensive than treatment. And what has been happening everywhere around the world is people are focusing on sick care and they're not focusing on health care. Healthcare is about prevention. Healthcare is about keeping the patient safe, keeping him from actually going to the health facility. Healthcare is about when a patient was sick, how do you accompany him back to the community? How do you keep advising him? So yes, it is a real issue in Africa where people like me still wait to be really sick before they seek care. But it's also a problem for the healthcare system in the sense that the healthcare system in Africa in general has been designed around sick care, not healthcare. To give you a couple of examples, the way people access healthcare in Africa in general is by paying a fee for service. When you're paying a fee for service, you're addressing the population of people that are having ailments that are mostly acute. You are addressing a population of people that do not have a chronic condition, because people who have a chronic condition tend to go to a health facility so many times. And when the payment mechanism is a fee per service, you are actually creating barriers to healthcare for them. The way the healthcare system has been designed does not prompt the clinician to be proactive with the patient, to consistently engage with the patient, to reach out to the patient. The way it is designed, it prompts the clinician to stay in his office and wait for the patient. And when the patient gets to him, he's going to try, and he's not motivated to keep the patient safe, to advise him, because he wants the patient to fall sick so that the patient can seek care and hence earn a living. I would say there's a lot to be done in terms of redesigning the healthcare system to mainly focus on prevention and healthcare instead of sick care.
In general, in Africa, the big problem is the lack of medical force. But I think that in Rwanda, that's especially prevalent, given the statistics that I mentioned before. So it's basically less than 0.1 doctor per 1,000 people. Can you share your perspective on how healthcare is in general addressed to be improved and to increase the number of medical staff? We will come to Babylon later, which is one intervention that trying to help access to healthcare information.
Thank you. Indeed, in Rwanda, we have a workforce issue in the field of healthcare. The latest data from the Ministry of Health, if my memory serves me right, is we have one doctor serving a population of about between 7,000 to 9,000 of population. This is still not enough. And the Ministry of Health, the government of Rwanda, has invested a lot tremendously in building new universities so that they can put more doctors out there. But when you look at the natality rate, the rate at which the population has been growing, and when you compare it with the workforce that is being put out there on the market in terms of doctors and nurses, you kind of feel desperate in the sense that you will never be able to close that gap. That is not the only intervention that the Ministry of Health has put in place. The Ministry of Health has built many health facilities in a bid to bring healthcare closer to the population. We used to have only 2 referral hospitals. Now we have, I think, 5 or 7. We have about 42 district hospitals. We have 506 health centers, and new ones are being built every single year. And they've introduced a new structure, which we are calling health posts, which is a health structure that is closer to the community. This is not enough, and the ministry has been considering new and unconventional way of providing health care access to the population. I'm talking here about the community health workers system. In Rwanda, we have about 60,000 community health workers, 4 community health workers per village. Each community health worker is specialized in a particular field. Some are more addressing more of the maternal and child health issues, and some others are addressing the rest of the issues in the community. So the government of Rwanda has been doing a lot to bridge this gap between the many patients out there that are in need of healthcare and the few health professionals that are out there. And indeed, they are also looking at digital health in general as one of the solutions to further bridge that gap. And this is where Babyl falls in.
What kind of digital health solutions are already present in Rwanda?
In Rwanda, apart from Babyl, and I know we'll be talking about what our offering is, and just to be brief, it is a telehealth service for now, connecting patients that are located in remote places with doctors that are here in Kigali. The Ministry of Health has also been trying different approaches. Some of them are telehealth models, connecting specialist doctors with other doctors, in essence, connecting health professionals and health professionals. There have been attempts to program to do with precision surgery. the King Faisal medicine. The ministry is also considering different approaches to link health facilities, health centers with community health workers. And there are also many apps that are being built, not by the ministry, but by individuals in Rwanda. Most of them are addressing one particular issue of healthcare. Most of them are disease specific. I know of an app that is aiming at addressing the issue to do with diabetes management. There is another app that is trying to fix the issue of appointment management. And actually, the King Faisal Hospital has an app that is doing exactly that. Babyl is, to the best of my knowledge, is the only app out there that is addressing mostly primary healthcare issue.
I have a lot of questions there. So one is based on the low number of doctors in Rwanda. How did you recruit doctors that work for Babyl? And the second thing is that Babylon is a UK-based app, so when it was developed, I'm assuming that it was developed for mostly based on the problems present in the UK. And when it comes to healthcare, problems are very, very environment specific. So how are the algorithms and the knowledge needed for the Rwandan population? How is this increased within the app to give as accurate information as possible?
Indeed, Babyl is a subsidiary of a global company specializing in digital health and AI, which is called Babylon Health, located in the UK, relatively a young company. We started in the UK in 2014. Indeed, the offering in the UK is based on smartphones because smartphone penetration is just very high in the UK. Also, the workforce constraints in the UK are not similar here. And indeed, the epidemiological models are completely different. We started in Rwanda in 2016 on invitation from the government of Rwanda. And when we started, the question was, what products do you launch with? And how do you plan to run your operations? The context was, in Rwanda back in 2016, phone penetration was said to be around 75%. But the way we count phone penetration, we're counting the number of active SIM cards. So in essence, phone penetration was even lesser than 75%. I would argue 50 to 60%. Now, when you look at smartphone penetration, it was said to be 10%. But actually, for the same reason, I would argue that it was actually maybe between 6 to 7%. So bringing a smartphone app was only going to address the issues to do with that limited portion of the population. We decided to launch a smartphone app, but concomitantly, we also launched a USSD version of our app. USSD being this, I would say, African technology that is now being adopted elsewhere, which allows a provider to communicate with a client by way of text messages without needing any type of internet connectivity, without needing airtime. And this is a platform that can work both on smartphone and feature phone. It has been used by telco companies for the likes of M-Pesa and mobile money, MTN. And it has managed to help countries as Rwanda start breaching the gap that has to do with financial inclusion and access to banking. We thought we could do the same with healthcare. So when I talk about Babyl app, I'm talking about both a smartphone-based app and a USSD app. So we launched both, but the reality is the smartphone app was not being used at all. Less than 1% was using the smartphone app, and most of the patients are using the USSD app. This one way of customizing the UK product. We looked at the need of the population and adapted our products. The other way of doing this is back in 2016, we were a bit worried about the level of connectivity and the level of access to computers that our doctors were going to have in Rwanda. To have some kind of control over that level of connectivity and access to hardware, we decided to operate from a call center-like environment. In the UK, doctors will make their calls from home. In Rwanda, we operate in a call center-like environment. That was the second customization. The third was, because we are treating Rwandan patients, it was important that we recruit local doctors trained in the local context that speak the same language as the patients. That was the third level of customization. Now, what we are now doing, we are in the process of introducing artificial intelligence to our processes, because if you allow me, I'm going to tell you in a few words how Babyl works so that you see how artificial intelligence is going to be pictured in. The patient picks his phone. It doesn't matter if he has a smartphone or a feature phone, dials what we call a short code, a USSD code, registers to our platform using his national ID number. The USSD flow is going to allow the patient to not only register, book an appointment, and make his payment using his mobile wallet. When the payment has been done, we call the patient. The patient never calls us. So the patient doesn't need to have airtime on his phone. The first person to interact with the patient is our triage nurse. Her role is to medically triage the patient and kind of assess how severe his condition is. If the condition is just too severe or it doesn't fit with the scope of digital health in Rwanda, the patient is going to be oriented within the healthcare system depending on his type of insurance and the severity of his condition. For around 70 to 75% of the patients, the condition is going to be deemed to be suitable for digital healthcare, and the patient is going to be put in connection with our in-house doctor that is also sitting in the call center. And the doctor has this possibility of issuing a prescription, a lab request, or a referral. The way it works, from the patient perspective, the patient is going to receive a short message, which is a code. The patient is going to take this code, let's say, to a partner pharmacy. They put the code into our system and the prescription pops up. The patient gets served and we receive feedback. We know the patient has been served. And we integrated our platform with more than 400 health facilities in Rwanda. Most of them are public. Some of them are private. It actually means wherever you are in Rwanda, you are able to access our service and get access to medication, lab tests, or referral services. This service is actually designed in a way that it is completely fit for the context of Rwanda. It's addressing the issues to do with connectivity, internet connectivity, the fact that most patients are living with less than $1 a day, the fact that we're still dealing with issues to do with literacy, the fact that phone penetration is still very low. So in essence, this whole process has been designed to fit the particular context of Rwanda and most sub-Saharan African countries.
Do you by any chance know if, for example, patients that are referred to a specialist or that are referred to a pharmacy to get drugs, if they don't pick up those medications or see a specialist, because this would mean that they would have an additional cost with accessing healthcare since everything is out of pocket paid?
First of all, let me precise that in Rwanda we have universal health coverage. And more than 93% of the population is currently covered by the population. So most of the payment is not out of pocket, even though the patient participates to the payment by paying what we call locally a user fee, a copay, which represents, which is about 15% of the total cost of the price of the consultation. So the patient doesn't pay the full amount. And indeed, by using codes, we can track the patient's flow and know if the patient has reached his point of destination or not, if the patient has redeemed his medication or not, if the lab tests were done or not. We also follow up with our patients. We call them back. We call those who have not redeemed their medication to understand the reason why. We call back on a monthly basis a representative sample of our patients to understand how satisfied they are with our offering. And actually more than 90% are saying they're really satisfied. By calling them, it gives us a very in-depth knowledge of what the pain points of the patients are so that we can address them and continuously improve the quality of our service. There is always a risk of a patient that have been digitally consulted to go a second opinion in a conventional setting. What we are finding out is a patient coming from a digital platform to a conventional setting for second opinion is happening actually less than a patient coming from conventional settings to another conventional settings, even though that risk cannot completely be cancelled.
To which extent do patients reach out to doctors and the official healthcare system compared to local community healers? Are there a lot of them present?
In Rwanda, indeed, we still have, in the structure, I started from the community health workers, but we still have traditional practitioners in Rwanda, and some patients still consult them before they even consider going to a health center or to community health workers. The Ministry of Health has put in place a system to, first of all, recognize them, know where they are, know what they are doing, give them a working framework so that at least you know what they're doing, so that you can actually leverage them as a workforce, because some patients actually trust them. So you better use them, but use them in a good way. More and more patients are deciding to use the conventional healthcare system. More and more patients are deciding, because women used to go to them even for things like deliveries, but more and more are going to health centers and health posts. And actually, Rwanda is one of the only countries that have managed to reach what used to be called the Millennium Development Goals in terms of neonatal and maternal death. And the way that has been achieved is by using unconventional workforce as community health workers for triaging patients, for reporting maternal and child healthcare issues, but also doing so by using technology, because the way they report those issues is by using a platform we call Rapid SMS.
Just to perhaps illustrate a little bit how healthcare delivery looks like in Rwanda, can you describe it a little bit? You were a chief medical officer for the Rwandan National Police, and you were even deployed for 2 peacekeeping missions, first in South Sudan, then in Mali. If you can give us a description, what kind of healthcare problems would you face on a daily basis as a medical doctor in Rwanda? And then we can move to the setting in the conflict zone. So, for example, you mentioned childbirth. Are they still mostly done at home? Just a general description.
As I was saying before, our healthcare pyramid is made of community health workers at the basis of the pyramid. Then you have health posts and health centers as a second layer. Let me precise that at the health center level, you only have nurses practicing there. You only get access to a doctor, a general practitioner, mostly at the district hospital level. The district hospital, the health centers, the health centers, the health posts and the community health workers deal mostly with primary healthcare issues. Secondary healthcare issues start being dealt with at the district hospital level. And then above that, you have referral and university teaching hospitals, as well as provincial hospitals. In Rwanda is a sub-Saharan African countries, and we share the burden of diseases that are present in all the surrounding countries. Mostly things to do with malaria. Rwanda is an endemic country for malaria. So we have quite some malaria, even though we have managed to keep it in check, to keep it in control with many interventions such as the countrywide distribution of mosquito nets. But our universal healthcare coverage also played a big role in helping those patients that are already sick to seek care very quickly. We still struggling with issues to do with malnutrition. We have managed to control acute malnutrition, but we still have quite some amount of chronic malnutrition, stunting for under 5. We used to have a big rate of HIV, but Rwanda is one of the countries that have managed to control the HIV rate by many interventions. And actually, we have managed to keep it at a rate of 3% for quite a number of years. We are now discovering that non-communicable diseases, and here I'm talking about things like cardiovascular diseases, diabetes, those conditions that used to be considered diseases for the rich countries, we are now discovering that they actually apply very much to us. As we screen our population, we are discovering high rates of cardiovascular diseases, non-communicable diseases, and we are only seeing the tip of the iceberg. And more of our interventions in the days ahead are going to be targeted toward management of non-communicable disease. In a nutshell, these are the kind of issues that the healthcare system in Rwanda is facing with, and workforce is a challenge if you need to address them. And this is why we are looking into innovative ways of addressing the gap between the few clinicians that are out there and the many patients that are suffering from these emerging conditions that we are more and more discovering.
So when you went to the two peacekeeping missions in South Sudan and Mali, how did your work differ from what you were doing before in Rwanda? Because that is a specific environment to work in. Was it mostly injuries or other problems also?
Some of the problems are similar in the sense that a person that is suffering is a person that is suffering. You cannot differentiate a suffering patient from Rwanda to a suffering patient from, let's say, Mali or South Sudan. The difference being Rwanda is a country that is very much structured. Even though we still have issues that we are struggling with, the structure exists. We know for which kind of issue where to go. We know for this kind of issue when to call an ambulance, which number to call. We know who is responsible for what. And this kind of structure you will usually not find in a war-stricken country like South Sudan. So the difference is mostly in the sense in the organization of the country. The difference is to do with what you can possibly do in a country like Rwanda and you cannot do in a country like Sudan and Mali, at least for the time when I was deployed there. The challenges I mostly faced with during my deployment in those countries were to do with displaced populations, refugees. And when you're talking about refugees, they have a particular set of issues that they're struggling with. They have little or no access to healthcare. They struggle with particular diseases like cholera. They have malaria. They have diseases that to do with the fact that they have little access to water, little access to healthcare. So those are particular set of conditions. What I learned in my working in that particular environment is sometimes what you think the population need is not what they actually need. I've seen many non-governmental organizations with the best intention possible trying to help, but actually just participating to the actual problem because the kind of service they're delivering is not needed, is not asked for by the population. I've learned a lot from working closely with those displaced people, trying to understand actually what their actual problems are and try to provide the solution. This you can see everywhere in the world, and I've seen it in Africa where people try to copy and paste a solution, not taking the product development or the service development, starting from the person that has the needs, understanding its needs, and from there developing a product, not the other way around. This is something actually that I learned from working with displaced people in those countries.
So what are the examples of help that is trying to be imposed on the people in contrast with the needs that are not seen or addressed?
Just to give you one example, and I will not name organizations or people here, I saw people bringing winter clothing in a country like South Sudan, where the weather is particularly hot. This is something that comes from a good place. This is coming from people trying to help. But in actual essence, people don't need those kind of clothing in those particular countries. People need the basic. People need security. People need access to water. People need access to food. People need coordinated action. People don't need standalone actions. So just imagine you are living in a country where the average temperature is 40 degrees and somebody's bringing to you a fur coat. What are you going to do with that?
That seems like a very uninformed way of trying to help, I must say.
Indeed. But also the fact that many organizations do not talk to each other. Many organizations do not coordinate. There are so many stand-alone interventions, which does not create efficiency.
But then there's also quite amazing technologies that are reported of being used. For example, Zipline being one of them. It's a drone delivery system for medical supplies. Do you have any experiences with it, or you must know more about it than me because you're, in Rwanda and I just read about it in the news?
Babyl and Zipline are these type of organizations that have been changing the way the game of healthcare is run here in Rwanda. In my days as a doctor in practicing in district hospitals, sometime in between, let's say, a surgical intervention, you would run out of blood. And the only way you could get a resupply was to send an ambulance when you have an ambulance available, because sometime back in the day you would have no ambulance, or not sufficient at least. You have to send the ambulance sometimes 4 hours, 6 hours, even more to collect blood. Just imagine the type of stress the clinician would be under. Imagine the type of stress the patient caregivers would be under. With the likes of Zipline, and I've seen it in hospitals where I've been practicing, within 15 minutes, you get your blood and you save the patient. So Zipline intervention has been life-saving, and it has actually revolutionized access to blood commodities here in Rwanda.
You were also a director general of Kabaya Hospital. Can you highlight a little bit how the challenges look like from the management perspective? In the West, there's always a problem of doctors being overburdened. But for example, Western hospitals would deal with questions like leadership, motivation of the workforce. And in Rwanda, where the shortage of doctors is really big, I wonder, how can you encourage doctors to be motivated to do their work? How much do they even have time or options to improve their knowledge? Because medical knowledge is advancing very, very rapidly. And I can't imagine how you can do that if you've got more patients than you can handle.
True. Practicing healthcare in a district hospital is not always easy. You operate in a resource-constrained environment. You deal with patients who sometimes cannot afford their treatment.
What happens in those cases when patients can't afford the treatment? Do they just get left out of the hospital, or?
They're not left out of the hospital. The policy in Rwanda is, first of all, every citizen should be insured. It starts from there. Sensitize the population to join the facing as managers of hospitals. Most of them are to do with the workforce, limited access to health practitioners, finances that are not really great, because you need to operate as an enterprise and be able to resupply in medication, be able to resupply in commodities. And sometimes it's just very difficult. But healthcare, the art of practicing medicine, it's an art. It's not, I like to see it as an art. It's not a job. You do not do it because of the art rate of a salary. You do it because you love what you're doing. Obviously, you have to be motivated by an incentive, but when the incentive is not regular, like tremendously, in terms of making sure that insurance companies are reimbursing the hospitals in time. We came from very far, and today we are at actually a very commendable place. In terms of making sure that the population is insured, from a place where we had a coverage of less than 20% back in the days when the scheme started, to a place where we now have 93% of the population insured, in the sense of motivating local authorities so that they can support district hospitals in their management. So challenges are there, but a lot has happened.
In the West, with the development of artificial intelligence, new technologies, smartphones, tablets, there's a lot going on in terms of how workflows are managed. In contrast, in Africa, the lack of IT structure is usually a problem preventing faster progress in healthcare. Can you describe a little bit what kind of technologies are used in hospitals or healthcare centers in terms of providing electronic healthcare records for patients?
Maintaining patient information, or at least reporting on that, start at the community level, with community health workers reporting on maternal and early childhood issues using the rapid SMS platform. In using that, they are able to notify district ministry level authorities, district authorities, and hospital level authorities when there is a red flag that need to be raised. When a woman, let's say, is delivered at home and is bleeding actively, they can issue a red flag and an ambulance can be sent to evacuate the patient. That is the first level. At the health center level, in some health centers, actually at the health center, in all the health centers, we have, as a ministry, deployed a version of electronic medical record. And most of it right now is dealing with the management of mostly HIV patients. The Ministry of Health has introduced an open MRS and a version of electronic medical record in some selected district hospitals as a trial. Now they're in the process of considering how they're going to scale it in all the hospitals so that at least every patient that goes to a hospital can have his information collected and stored in an electronic medical record. Because the reality is currently, if a patient goes to a district hospital, his file is a paper file that can be misplaced. That, if stored, requires a lot of storing place. It requires somebody to actually be employed to manage that archive. It's just not efficient. It is dangerous for the patient currently, because if you cannot get access to a patient past medical history, you are likely to prescribe medication that is not suitable for that particular patient. You are likely to ignore condition that the patient suffered from in the past. And the ministry recognizes that and is investing a lot in scaling up this electronic medical record. But we are not yet there. We are still at the beginning of that process.
Is that a sort of a national electronic healthcare record? Where is the information stored? And, can a doctor from a different hospital access information of a patient from a different part of the country?
Currently, no, because the different modules that have been piloted in the few selected health facilities are not yet talking to each other. So it actually means you run the risk of having different health records depending on those different health facilities you're going to. And this is exactly the issue that the government of Rwanda is trying to solve by creating a national electronic health record that is going to be used countrywide, so that it doesn't matter where you go, the clinician can still have access to your health record. This is where we are heading.
What kind of devices are used for data gathering? I mean, computers get old very, very quickly. It's no different with tablets and mobiles, and there's the question of affordability. So how do you gather data?
Data is mostly gathered using computers, laptops and desktops mostly. And we still do not have enough of them out there. But in the last 5 years, the government has been procuring a lot of hardware and putting it in the different health facilities in a bid to prepare for the countrywide scale of the electronic medical record. Because we recognize that it is an essential tool that has to be there. We still have a lot of inefficiencies, even in using our workforce. When a clinician has to deal with a lot of paperwork, it makes him less efficient in the way he's delivering healthcare. It makes him spend much time writing on paper instead of focusing on the patient care. When we are using paper bills, paper invoices, it makes us less efficient in the recovering of the money that has to do with the care that we give. By introducing automated processes, electronic processes, we are hoping to bring efficiency. So we are very far from that. And the ministry is still procuring hardware, procuring computers, and actually trying to figure out which electronic medical record is suitable for our market so that they can launch it. And it is my understanding that we are really close to achieving that.
I must say that to a certain extent, I'm surprised that there's a lot of focus on computers as the hardware part of providing healthcare, because, less developed countries have the opportunity to leapfrog in development and avoid some of the technologies that have been used in more developed countries where the development was more gradual. For example, I still remember when I was in India and they tried to digitize healthcare, they used special tablets because they're also more portable and easy to use in the rural setting where healthcare workers potentially need to move around,
Indeed, you're right. Africa is at this particular point where we have the possibility of leapfrogging, actually leveraging the knowledge accumulated elsewhere to use it to leapfrog and actually achieve universal healthcare. In my understanding, you still need both because portable devices are needed, but they have advantages and they have inconveniences. Portable devices are indeed needed when you're talking about a wards tour, a doctor who is visiting his patient. He needs a portable device to be able to take the information down. A community health worker that is doing home visits will need a portable device. But portable devices can be stolen. Portable devices can be more easily broken. You have pros and cons for each type of hardware you're using. In countries like Rwanda, we still need access to the basic minimum. At least a computer, let's say 3, 4, 5 computers in a health center, that is already a big step forward for us. There are now manufacturing companies that manufacture computers here in Rwanda, and access to hardware is becoming easier and easier. And hopefully now we are going to take a step forward and start manufacturing locally tablets and those kind of devices. We're already manufacturing smartphones here in Rwanda. We are manufacturing computers. So hopefully we are getting there.
How did you first get in contact with Babylon?
A friend of mine who was the first employee to be recruited by Babylon here in Rwanda reached out to me. I was working for the Ministry of Health. I was managing a hospital. He reached out to me and he was like, would you be interested in working part-time for this telehealth company that is going to start very soon? So I applied for a part-time job as a clinician to do telehealth consultations. And instead, they proposed this senior position to me. They were like, yes, we know you applied for this junior position just doing consultation, but looking at your profile, we think we can trust you with this more senior position. This is how this adventure started.
What kind of statistics can you share with us today? Babylon's technology was launched in Rwanda in 2016. How many users have used the platform so far? How many users are registered? What is the daily number of online consultations? Anything that you find relevant?
Since we started operating in 2016, we have managed to register more than 2 million people to our platform. 2 million people in a population of about 12 million. That represents about almost 30% of the adult population in Rwanda. So we've managed to register quite a big number. And all these 2 million people doesn't mean that they've used our platform to have a consultation. Among them, more than 700,000 have actually consulted with us. And most of these appointments have happened within 15 minutes of wait time. So the patient has gained as benefit. We have saved time and resources to the patient. We have a workforce of around 100 doctors and 120 nurses working for us on a part-time basis. This actually means that they're still working for public hospitals. They're still working for private clinics. We are not stealing the few resources that are available in Rwanda. We are actually leveraging the resources that are out there to kind of create virtual doctors out of thin air. So in their free time, we employ them. We give them a second source of resource. I would not say it's not only out of good heart. It's a benefit as well. If they continue working in their own settings, conventional settings, we benefit from the experience they're gaining from actual practice, bedside practice of medicine. They can bring it on a digital platform. And the experience they're gaining from working on a digital platform, they can transfer it back into their hospitals. We've been conducting the last couple of months, on average, between 2,500 and 3,000 consultations every single day. This represents about all the consultation that would come from about 4 to 5 district hospitals in Rwanda. There is an independent study that was done at the end of last year by an independent consulting firm called Dolberg. They conducted an impact assessment study, and they actually showed that patients reported that they reported some financial saving. They reported a lot of time saving. 90% of the patients reported being satisfied as compared to 80% in conventional settings. The impact study showed that we, in our approach, equitable to both men and female in the way they are accessing healthcare through our digital platform. And 80% of our patients are calling from rural areas as compared to 20% alone in urban area. Because when you're talking about digital health, people would assume that it would mostly be used by the elite and mostly in town. But this is not what we are seeing in Rwanda, because actually it makes sense, right? Where there is the most need is in the countryside. In Rwanda, more than 50% of the workforce, the clinical workforce, is situated in Kigali, and actually most of the need in the rural area. So it makes sense that most of our calls are coming from there. These are a few key facts as to our impacts in our years of experience here in Rwanda.
Are you getting a lot of inquiries from other doctors to join part-time as well?
Indeed. When we started, I do remember in 2016, the first doctors that I recruited didn't come because they believed in digital health. They actually had no clue what digital health was. They joined, most of them, just like me. They joined because of me, because they trusted me as their friend. They came to help me out because I couldn't find good doctors out there. With time, as we are building our brand, as customers are giving witness as to the quality of care we are giving, as we are being exposed more and more to doctors out there, they get to know us. So now we're in a place where actually we have doctors applying spontaneously without me going to look for them. So yes, indeed, we are in a so much better place.
What about patients? I heard that there's a lot of advertisement of the app in the country. How are you trying to reach out to the rest of the population? 2 million, as you said, is still 1/3 of the adult population.
Indeed, if you have a product that you deem to be suitable for a particular service, however how good your product is, it doesn't mean that the patient is going to use it. And we have learned this the hard way. It takes time. Behavior change takes time. You're talking about an adult, let's say 30 years old patient that is used to going to a health center to seek care for simple colds. He would rather go and queue for hours to get a consultation by a nurse for simple cold. And now you're telling him that condition you're taking to a health center where you find a nurse wearing a white coat and a stethoscope around the neck, the same type of condition can be dealt with quite safely over the phone. It doesn't happen overnight. It requires a lot of explaining, a lot of experiencing. So indeed, we have been educating the population as to what digital healthcare is and what the benefits are. We do not advertise because advertisement in Rwanda is regulated and you're not supposed to advertise healthcare services. But we are allowed as a provider that is bringing an innovative product that people are not used to reach out to the population and explain what is the benefit of digital healthcare. So yes, it took a lot of time. It took us 2 years to reach.
Advisor to the Minister of Youth, Grace Mukabekazi, expressed a hope that women and girls would inquire about healthcare problems through the app and get informed about things that they otherwise could not get to because of social constraints such as embarrassment or judgments. Do you see any of those inquiries coming in?
Digital healthcare can address most of the healthcare issues. But in my years of experience here in Rwanda, practicing telehealth and digital health, I've seen this technology attracting some particular group of people. One of them is patients suffering from conditions that normally deal with or are confronted to stigma. I'm talking about HIV. I'm talking about mental health. Those patients tend to feel more comfortable when their issues are being addressed over the phone. I don't know why. Maybe they feel like because just put this into context. If a patient goes to a health facility in a community, the nurse, the patient is going to find there is mostly, they know each other. It's his uncle, his aunt, or the nurse knows his uncle. So if you're going there for HIV screening, sometimes as a patient, you feel like your health information is not safe. Your health information is going to be divulgated in the community. That's how patients feel sometimes. And they feel safer when it happens over the phone. So things like HIV, mental health, and sexually transmitted diseases. These are conditions that we are seeing a lot of patients calling us for those kind of issues. And these issues, usually a lot of women face them. We're talking about things like family planning. 2 days ago, I received a call from a 15 years old sexually active young girl that just wished to ask questions about what kind of family planning method she could use, if she could use any. And her reasoning was, at my age, if I went to the health center nurse is my aunt. What would I discuss with her? I would never take these kind of issues to her. Indeed, healthcare through mobile phone can really help with issues that are to do with women specifically. Advice to do with vaccination, antenatal care advice, postnatal care advice, breastfeeding issues, family planning, sexually transmitted diseases, all these issues that women sometimes do not need actually medication for, but just to have a health practitioner they can talk to about is already tremendous.
Given the need to have a local expertise to help the patients, how scalable is Babylon throughout Africa, and what are the plans for entering other countries as well?
Well, first of all, within Rwanda, we are hoping to even some more, to even address those people who currently do not have smartphones. We are in the process of considering what other type of innovation we can bring about so that people can benefit of telehealth even if they don't have access to phones. And we are looking forward to all the efforts done by the government of Rwanda to even give more access to phone and smartphones to the population so that we can start introducing smartphones application and artificial intelligence enabled applications. We are in the process of localizing our artificial intelligence in Rwanda. As you mentioned before, the artificial intelligence has been developed in a particular context, which is a Western context with Western algorithm. We are now in the process of integrating the regional epidemiological models, in the process of having the tool customized by local doctors and nurses, and actually having it translated in the local language, which is Kinyarwanda. The aim is to use this artificial intelligence for triage in our call center and deploying it in health centers, public health centers, so that health practitioners can leverage this AI to better triage and create some efficiencies in those two settings, in the hope that smartphone penetration will becoming higher and higher. But as it's becoming higher, at least patients can benefit from it if they go to a health facility or if they call Babyl. And when smartphone penetration becomes higher, we wish to take this application and put it in the hand of community health workers, put it in the hand of just anyone who has access to a smartphone. We are ambitious. We want to scale throughout Africa from Rwanda. We have different models that have been applied in different countries. We are not only in the UK, we are in Rwanda, we are in Canada, we are in the US, we are in Southeast Asia, different countries, different models. We have a lot of knowledge that we have gained during the years of practice, and we think these models are applicable, but you will never copy and paste. Every country is different, and our approach will always be start from a need-based, start from a client telling you what he needs and develop the product from there.
You've been listening to Faces of Digital Health. The next episode, the last one in this short series about digital health in Africa, will feature the state of healthcare in South Africa. Stay tuned, subscribe to the show to be notified about the next episode automatically, and do leave a rating or a review wherever you get your podcast. It really helps other listeners interested in the topic find the show as well. Thank you.